Good afternoon, everyone. It is a pleasure to host you on our virtual session today entitled Tailoring Different Device Options to Improve Safety and Efficacy in TAVI. The session today will be moderated by Dr. Bargaith from King Abdelaziz Medical City National Guard in Riyadh, and Dr. Bargaith is the Vice President of the Saudi Heart Association. Our speakers today will be Dr. Faisal Al-Goufi, Director of the Cath Lab in Johns Hopkins Aramco Hospital, Dr. Christian Smith, the Chief Cardiology of Interventional Cardiology, and Dr. Alexander Wolf, Senior Interventional Cardiologist and Cath Lab Lead from Essen Hospital in Germany, and Dr. Daniel Blackman, Structural Heart Lead in Leeds General Hospital in UK. So without further ado, I would like to invite Dr. Bargaith to kick off the session and take us through the session objectives. Thank you.
Thank you very much, Michalis. It's a pleasure tonight to have our colleagues from different parts of the world. We got Faisal from Saudi Arabia and Dr. Blackman from UK and other colleagues from Germany. Today, we will talk about the tailoring different device option to improve mainly the safety and efficiency of choosing a TAVI device in your patient. And the objective of that is to keep more safety for those patients. And you know, it's a big subject now in the cath lab. Most of us, we are doing the CT scan and then we decide. Most of the companies now, they are competing with each other to improve the technology. And this improved a lot of our result in the cath lab. When we started like here in Saudi Arabia 10 years ago, with the TAVI program, and we compare our result 10 years ago with the new technology and the new advancement with the results we are having nowadays, it's a big difference. And to start our session, we're going to start with our colleague from Eastern Province, Dr. Faisal Al-Goufi, who will talk about introduction of ACURATE knee. Faisal.
Thanks, Dr. Bargaith. Thanks for the opportunity to be in this sessions, and thanks for Boston and Saudi Heart. I'm just going to go ahead and share my slides. I am going to give initially an overview of the device. Can you see the slide well?
Yes.
So the ACURATE new with 1C is a self-expanding valve. We're going to talk briefly about the ACURATE new 2 towards the end of the slide. Self-expanding platform with positioning that actually comes top to bottom compared to the currently available, commercially available valves, where the deployments come from the bottom top. The technology has two parts in the deployment. One is the stabilizing arch, which, as you can see here, give you some stabilization during deployment. Very handy when dealing with cases of significantly horizontal aorta. Then the upper crown, which usually comes initially in the deployment, it provides some stabilization, but also help with capturing the native valve leaflet. The last part of the deployment, which is basically the lower part of the device, has a very minimal footprint in the LVR flow tract, which clearly has been favoring the pacemaker rate with this valve. The ACURATE Neo has the pericardial skirt. The newer version will have a cuff similar to the other platform that's available in the market. The current the valve is a porcine pericardial valve. As usual with self-expanding valve, the valve hemodynamics actually is very favorable with a higher effective orifice area and lower gradients in general. Small to medium sized annuli. The current size is between 21 to 27 millimeter annulus could be treated with this valve. The delivery system, I have to say, is very versatile, tracked very well. The sheath which will deliver, I will show you towards the end, but a minimum diameter of 5.5 with the eye sleeve is enough to deliver the system. The system usually comes with a loader that protects the valve as it enters the eye sleeve. Once you pass the sheath, then you could bring the loader back. The deployment is 2 stages with 2 clear wheels. Each wheel has a nice arrow to direct the operator how to deploy the wheel. Very self-intuitive, as you will see in the subsequent slide, but trackability is, again, very easy with the system as we tried it. The current version has a clear radio-fake marker. We were told in the newer version it will be even more obvious. That helps the operator to position the valve in relation to the native annulus and in relation to the pigtail that is usually in the non-coronary cusp. This valve usually delivered in a forward motion, meaning once we reach that position with the appropriate tension on the wire, the primary operator or the operator that is handling the system is really keeping the valve steady, while the secondary operator is handling both the knobs and also the tension in the wire. As far as the cases that we've been involved in, we did not need manipulation of the wire during the deployment. Notice that the hemodynamics is very stable. There is no need to pacing during the deployment. The first part of the deployment, usually by releasing the stabilization arch with the upper crown, this part tends to be slow, and subsequently the lower part or the second knob tend to be quick deployment. This is a video of a case I will show you, and you will see the subsequent case. But the valve in general, radio, this marker that I'm pointing to is very obvious under fluoroscopy in relation to positioning the valve. The upper crown usually comes, it track or it captures the native annulus, and basically the stabilization arch also, when it's fully deployed, tend to make the valve stable. The lower part, which you can see here, is a quick deployment, and as soon as it deploys, the radio opaque part of the valve tends to descend towards the LV. There are three sizes to cover the medium, small, and small, medium, and large. But the first generation of this valve came in around 2012 via transapical route. Subsequently, 2014, they achieved the CE marks for transfemoral, the ACURATE new, which this is the current available form. And soon we will have the third generation, which is the ACURATE new 2, with the basically sealing skirt, similar to other platforms that has been shown to reduce PVL as comparable to the Evolute Pro and the Sapien 3. The eye sleeve, which really, in a personal experience, I think it's really an amazing sheath, hydrophilic, tracks very well. I tend to suture it because it's really very hydrophilic. But overall, the minimum diameter is 5.5 to use this sheath, and I think in terms of trackability over difficult anatomy, we have tried it in 2 cases with excellent results. This is my part where talking about the device overview, and I'm just going to stop sharing here. Happy to answer any questions.
Thank you very much, Faisal. And I think let's have like one of our clinical practice cases, or it will be Dr. Wolf Alexander from Germany. He will talk to us about how I would treat a case review. And we try to make this session more interactive between us and the audience. Dr. Wolf.
Yeah, hello to Saudi Arabia from my side. I think the clinical cases from our center will be showed by Dr. Schmitz.
Sure.
That he will show the clinical cases. Okay?
Okay, thank you very much. It's a great pleasure to join your meeting. It's Thomas Schmitz from Germany. And we have 2 cases prepared for today, and I want to start with them.
Good.
So let's share the screen. I hope you can see everything.
Beautiful.
Okay, so our first clinical case we want to present today is a female patient, 85 years old. She came to our hospital with dyspnea. You can see NYHA 3 to 4, and the admission was because of heart failure symptoms. Her comorbidities are 60% stenosis of the ACE on the left side. She has hypertension. She's a little bit frail. Her height is 155 and her weight is 60 kilograms. And as you can see in the TTE, The ejection fraction is 60%, so good ejection fraction, but really a severe aortic stenosis with a mean gradient of 103 mmHg. So the logistic Euro score of this patient was about 18.81. And we discussed the case in our heart team, and the decision was for a transfemoral TAVI. So on this slide, you can see the CT scan, and very important are the measurements. You can see the perimeter is about 22.2 and the perimeter is about 69.9. And as we heard in the presentation before, this would be the size for the small valve, the S valve. So we decided to use in this case the S valve. And here you see another view. And what you can really see is a lot of calcification at this and at all leaflets. So really a severe aortic lesion. And it was not so easy to pass the aortic stenosis. And you see the invasive gradient was really impressive. So high gradient aortic stenosis. And the next step was then the predilatation. So at the moment, we always do a predilatation for implantation of the ACURATE valve. This is a 20 millimeter balloon, ACURATE true dilatation balloon. And this was done. And then you see the implantation of the valve. So it's really important, as also with the other devices, to the three cusps. And then you can see, I hope you can see it, there are three small markers on the valves, and they have to be aligned with the annulus. And then you can implant the valve during a kind of fast pacing. So normally we pace with 120, and then you can safely implant the valve, but it has to be at this position. And then as we had heard in the in the previous talk, so first the upper crown is opened. So this was knob 1. And if you still have a good position, you then turn the knob 2, and the rest of the valve is opening, as you can see now. And as you also can see, it's very stable and a good radial force in this case. And the measurements after the implantation was excellent. So just a P mean of 7 millimeter Hg and really no relevant aortic regurgitation. So I think for a case like this, with a severe stenosed aortic valve, an excellent result for the patient. So this was the first case. And the second one is a male, 77 years old. He came to our hospital also with heart failure symptoms. His comorbidities are diabetes, hypertension, and he already had a CABG. And in the transthoracic echo, you can see an aortic stenosis with a P mean of 43 millimeter Hg. So also a severe aortic stenosis. The logistic Euro score of this patient was 21. And in the heart team discussion, he was also decided for a TAVI transfemoral. So now you see the CT scan of this patient, and we have now a perimeter of 79. And the annulus was about 24.9. So this means this is at the border between M and L, but there was not a lot of calcification. So we decided to use the larger one. So if you in doubt between two sizes, if there's a lot of calcification, we normally choose the smaller one. If there's not a lot of calcification, we choose the larger one. And the second problem in this patient was a really horizontal aorta. You see it on the CT scan on the upper picture and also here. So very horizontal, and this is sometimes difficult to have a good positioning of the valve. So now you see the pigtail in the left ventricle and the marker pigtail in the non-coronary cusp. And in this case, we did a predilatation with a 22 millimeter balloon. That is a predilatation. And the next step is now, again, the positioning of the valve. You see the three markers. Now with the new one, it's a little bit easier. There's only one marker in the middle, but here are three markers and they are aligned with the three cusps, as you can see here. And then again, you start to rotate the knob number 1, and the upper crown is opening. As you can see here, very stable position. And then the next step is the knob 2. The valve is opening, and you can see really nice opening, good acute result. and this was the angio after implantation, and also maybe a very trace aortic regurgitation, no gradient, so really good result for a patient with a horizontal aorta, where it's sometimes a little bit difficult to really find a good position, and also the manipulation of the valve is sometimes a little bit difficult. So these were two cases from our hospital, and thank you very much for your attention. Sorry, we cannot hear you.
If I can ask you a question, this is very nice case. Thank you very much. You know, one of your cases was the horizontal, and one of them was the small annulus with calcification. And if you have maybe 2 or 3 self-expandable valves on your shelf that day, like, for example, which we are not using, Portico and Evolute R or Bro for the calcific, and the ACURATE New. Can you give us more messages, take-home message from your cases, how you're going to differentiate in using which is what, like, what was the preference here? Because what I can understand from your case presentation, that the one with a smaller annulus or more calcification, you're going to use a small valve. Is this true?
So with a small annulus, it depends on the sizes of the perimeter, and we did the measurement, and for this case, the best thing was to use the small valve, the S valve, but you can also use a small Evolute Pro. But in this case, we decided to use the ACURATE one. For the horizontal, it's a little bit easier to find a good position, and the manipulation of the whole system is also a little bit easier with the ACURATE Neo comparing to the Evolute R. The experience in our center with the, you said the name, the third valve,
Portico?
The Portico is,
yeah,
very rare, because we used it a little, I would say 10 times, and the results were not so good in our opinion. So we do not use it anymore.
Yeah, because I visited a few years ago Copenhagen, Lars, there, and he was using Portico valve at that time, maybe for a trial or whatever. Here in Saudi Arabia, still there is some limitation of usage of Portico and ACURATE New. It's not widely spread in the country yet. The 2 main valves we are using is the Medtronic and S3 nowadays, Edward. But it's approved, like at least the ACURATE New or Boston Scientific, it's approved in the unified purchasing in the government.
Another advantage for the ACURATE Neo in the first case, where you had this really heavy calcification, is also, as you know from the study data, the pacemaker rate is a little bit lower, and the access to the coronaries is easier when you use this valve.
Because of the wider...
Sorry?
Because of the wider...
Yes. Especially in cases where you have a lot of calcification, then it's easier.
Excellent. Somebody asking, please, for the pre-dilatation, should it be full valve dilatation or not? And what if full valve dilatation was not achieved? Like with ACURATE New here, like pre-dilatation, so far it's mandatory or preferable. But I'm not sure if you don't have a lot of calcification. You know, sometimes we see valve, even we are worried about the anchoring because of the calcium, not that much.
So if you look at the IFU, it's still mandatory. But I know that a lot of colleagues are doing in the CT scan a kind of calcium score of the valve. Right. And if this calcium score is very low, they also do a direct implantation, as we do with the S3 and as we do with the Evolute. And if we do a pre-dilatation, we normally take the balloon one size smaller. So in this case, it's a 20 millimeter balloon. Mm-hmm. And if you have to do a post-dilatation, in that case, we would use a 22 millimeter balloon for post-dilatation.
Faisal, is this your turn after? You're gonna show us a case or what?
Yes, 1 second.
Because in the old schedule, it's your turn.
Okay. You have a case. Let me just share my slide, please.
Sure.
Sorry, I apologize for
No
the
problem.
delay. Can you see my slide now?
Yes.
Okay, so my case is, I think, mainly about the choice of the valve. But nowadays, we are,
We see
try
your
as-
screen. We see only your screen, but not the real slides yet.
Okay, then I'll stop sharing. 1 second.
Thomas, somebody's asking in the question and answer about the rate of pacemaker with this new valve in your center.
It's between 8 and 10%.
That's good. Can we say it's between Edward and Medtronic?
Well, I would say in our experience, it's even lower than both of the other one.
That's good. Great.
Alex, what do you think?
Mohammed, I'm just having some technical difficulty that I have to close the PowerPoint. If you just go to the next speaker, I'll definitely bring the slide.
I will.
We have in our center around about 8%, 8.9% of the ACURATE valve pacemaker rate, and it's slightly higher in the S3 valves. Yeah, but S3 and ACURATE, we use them in our screening predominantly also for patients which have a right bundle branch block as a first line choice, one of those two valves, just in order to avoid pacemaker afterwards.
Are you able to see my slide now?
Yes, yes, very good.
Okay. So this is a case of a 72-year-old female with a history of type 2 diabetes, hypertension, atrial fibrillation, chronic kidney disease. She does have a high BMI with obstructive sleep apnea and CPAP, very limited mobility, mainly due to severe osteoarthritis. Her essential frailty 2, she scored 2 mainly because of the limited mobility. She does not have any significant dementia, no problem with her hemoglobin or albumin. She did have an echocardiogram, which showed overall normal systolic function. She does have grade 2 diastolic dysfunction, very mild mitral regurg. She does have moderate hypertension, severe aortic stenosis with a mean gradient of 44, maximum gradient of 74. She does have a valve area of 0.79 square meter. And as if you remember, this lady had also high PMI. So her coronary anatomy prior to the TAVI procedure showed focal middle AD stenosis that we elected to do angioplasty once our heart team meeting has been concur about the decision about which aortic valve intervention. So she had a single visual disease and she underwent an angioplasty to the middle AD. Her CT scan showed a perimeter of 70.9. One of the main concerns in her CT analysis was that she does have a borderline low left main, yet her sinus was generous. She did have good access for consideration of any current platform. She does have an anterior calcification involving the sinotubular junction, symmetrical calcification of the aortic valve, but it is not, I have to say, it's not a heavy calcification. Her ECG showed the right bundle branch block with atrial fibrillation, and she does have so far 2 predictors for the need of a pacemaker. So the heart team meeting showed that she does have, when we met, we had a low STS score. The main feature that is not captured in the STS score is actually her poor mobility. She does have a high PMI, pulmonary hypertension. But if you look at her, she would be in the low risk category based on the STS score, yet because of her poor mobility and high PMI and anticipated stay post AVR, the team favor TAVI procedure over a SAVI procedure. So may I ask here, with this information, which platform would you use with the current available platform in Saudi? Any comment from the panel?
I mean, there is almost a discussion between us and the surgeon, especially for the low STS scoring and the age. I think this patient was 70 something, right?
72.
72. And she is a low risk. But I
By
think,
STS,
yeah, she's less than 4.
but she had a BMI of 45.
45, no surgeon will take her in this country.
Yeah, so
Let's ask our colleague from Germany, then Daniel, if he is with us.
Yeah, I mean, I think in terms of valve choice, one of the factors that would influence us would be the heavy calcification at the sinuotubular junction. We avoid balloon expanded valves with severe STJ calcium, mainly because of the risk of annular rupture, but I think there's also some risk of the balloon interacting with the STJ and causing the valve to move during deployment. So that would lead us to use a self-expanding valve, such as Evolute, which is, you said, was your main alternative that you have in Saudi, or in fact any of the other valves, Lotus, or ACURATE, or Portico. None would have a problem with that STJ calcium, but we would avoid Sapien with STJ calcium like that.
Are you happy with the lift main distance flow at 8.4? Or?
Yeah, I mean, I think in terms of preserving, I mean, I think from what I recall of the dimensions, the sinus of Valsalva was wide enough to mean you probably wouldn't be too concerned about obstructing the coronaries. I think, you know, we have used ACURATE in our center for cases where we're concerned about coronary obstruction. And I think we do believe that the upper crowns can help in pulling the displaced leaflets below the coronary arteries. So that can be useful. And I think the other question following your PCI is reaccessing the coronaries. And I think, you know, our favored valves to preserve coronary access would be Sapien or ACURATE.
Sure. I think those important points were actually part of the discussion. Coronary access was one of them. The low lift main, although the sinus was generous, but was also a concern. In addition to the fact that she does have the risk of needing a pacemaker. So based on our assessment, we elected to go or choose an ACURATE new valve. The size based on her perimeter was chosen to be the S size. The procedure planning was for the procedure to be done by general anesthesia. And the reason for that, despite her high BMI, is the fact that we are anticipated major difficulty reaching to the femoral artery and doing our percloses. Also, she clearly had significant degree of arthritis to make her be able to lie on the table for an hour. We elected to predilate. We undersized the balloon intentionally because of the STJ calcification. If we use the recommended balloon, it would have been a 20, but we used an 18 ZMED balloon, and we will assess the need for post dilatation, post deployment. This is the aortogram, and similar to the other valve, this is a coplanar angle in order to deploy the valve. We had a pacemaker for the pre-dilatation, but we were not planning in pacing during deployment. The balloon dilatation was uneventful, tolerated very well hemodynamically. The deployment of the valve, I'm just going to point out to the radiopaque marker here, and there is a bit of calcium that is actually below the annulus, and this is the non-coronary cusp. So our pigtail is at the end of the non-coronary cusp, and there is a line of calcium below the non-coronary cusp. The deployment was without pacing. The patient was hemodynamically stable throughout the deployment. Slow deployment for the first part, which is the upper ground and the anchoring part of the valve. This is the upper crown coming up, and basically you will see that it will anchor some of the leaflet. These are the upper part of the valve, the upper crowns. This is the lower part, which usually tend to be a very quick deployment. And as I said, no much manipulation in the wiring to achieve this position. Once we are in that position, usually the wire is very stable. Post deployment assessment showed no significant paravalvular leak to warrant post dilatation. And with all honesty, we needed more than a mild paravalvular leak to take the risk of post dilating here. Her ECG 6 months post deployment or post implanting the valve was still right under branch block with AFib. She does have mild paravalvular leak. The mean gradient is 12, which we felt very good for a lady with a PMI of 45. We were expecting some patient prosthesis mismatch, probably with any device, but if we used maybe a balloon expandable, maybe our gradient would have been a bit higher in this lady compared to a self-expanding valve. In summary, in modern day, TAVR center should have access to more than one TAVR platform. The TAVR device in the future should be individualized and tailored to patient anatomical factor, risk of postmaker, potential need for future coronary intervention. And thank you.
Thank you very much, Faisal. Excellent. We had a question for you. Somebody's asking what mode of anesthesia you use in this particular lady, general or conscious sedation?
I actually use general on this lady. We do a lot of conscious sedation. Previously, we were part of the M3M trial, which changed our perspective. But you have to individualize general versus conscious. And in this lady, in terms of the patient choice, our choice would have been general, mainly because our anticipated difficulty getting into the access, given how the high PMI, and the fact that she will not be settling in a table with significant degree of osteoarthritis.
And somebody is asking if this type of valve is retrievable and recapturable.
No.
Maybe I will take one question to Thomas, and that question about heavy calcification. Do you think there is, before you use it, are you thinking about the incidence of stroke? And in that case, which valve you prefer? Is there any data preferring which valve on the other ones if your valve is heavily calcified?
So if you compare the scientific data for the valves, I think there's no significant, really significant difference between all valves regarding to stroke data. So in some cases, we are discussing about a protection device like Sentinel, but normally in the heavily calcified valves, we just use the valve, as our colleague mentioned before, which is the best one for the patient. So in our presented case, it was the ACURATE. There are some cases where we also use the Evolut one, but there is in our clinical day, we don't see a really difference in the stroke rate between the two devices.
Okay, great. I think the turn for Alexander. Is this true, Alexander? The evidence review, who will give it?
I'll give the talk on the evidence.
Excellent.
Yeah. So can everybody see my screen?
Yes.
Okay, then I'll start with the presentation. So ACURATE Neo, where do we stand in terms of the data nowadays? So if we just take a little step back and we think about what is an ideal TAVI device, it is a device which has a very high procedural success rate. So it is deployed where it should be with a good result and a very low complication rate. So complications is, for one, all-cause mortality, then it's PV leak, pacemaker rate, stroke rate, and also the rate of vascular complications, not to forget that. So where do we stand with the ACURATE? And I'll take you a little bit in the history back. These are data from the TAVI-TF registry. The TAVI-TF registry was a post-marketing registry with 1,000 patients included in a single arm, 25 European centers, all three valve sizes, which accommodate the annulus from 21 millimeters to 27 millimeters, were included, and the primary endpoint was all-cause mortality at 30 days. But keep in mind, these are post-marketing data, so these patients were also selected with a suitable anatomy. So the secondary endpoints were procedure success post-implant and the performance of the valve at 7 days and 12 months, including also the work to safety points. This was published 2018. And if we look at the baseline characteristics, it's clearly a high-risk cohort, patients on average over 80 years, like it is in Germany, predominantly female patients, in logistic Euroscore 18.1. And if you look at the STS, you can discuss if these were intermediate patients. For us, like we mainly go from the logistic Euroscore, and like this is classified a high-risk cohort in our centers. And we had a mean gradient of in the echocardiography of 42.7 with a valve area of 0.7 at baseline. The procedural characteristics, what you can see is we had just about in nearly all cases 96% of pre-dilatation, which is also in the IFU recommended. But we also had 44 or nearly 45% post-dilatations of the valve. So we talked about already, we mentioned the need for rapid pacing. You don't really need rapid pacing to deploy the valve. You can do it with a fast pacing in order to suppress ventricular extra beats to have a more stabilized output during the deployment. But you don't really need to do that if you have a stable situation and the valve doesn't move too much against the annulus in the pre-deployed state. Yeah. So the device usage time is also important. It was in that registry around about 6 minutes, and we had a procedural success rate of 98.7%, and no cases of annular rupture or ventricular septal perforation. So the discharge echocardiography showed very good gradients. The gradients dropped to mean gradients of 8.4. in echocardiography and valve area of around about 1.8. And the primary endpoint at 30 days was an all-cause mortality of 1.4%. With that already mentioned procedural success rate of 98.7%. So what was the leak situation in that registry? We had at discharge 4.1% moderate paravalvular regurgitations, and at 1 year we had 3.4% moderate and 0.2% severe PV leaks, with a follow-up of 587 patients. So let's look at the safety endpoints. We already talked about all-cause mortality at 30 days. That was 1.4% and 8% at 1 year. The stroke rates at 30 days was 1.9%. MI rates were low, bleeding were low, and the pacemaker implantation was 8.3% with this valve in this particular registry. So if we moved forward in the history of the data which is available for this ACURATE Neo valve, it's the head-to-head trials which were coming up, and there was the SCOPE 1 trial, which was a randomized trial, was including 700 patients designed for non-inferiority in a multi-center fashion. With the primary endpoint, it was a modified combined endpoint of early safety and clinical efficiency. I'll show you some data after. And the SCOPE 2 trial, it's also a randomized trial where the data was just presented at TCT. Also 764 patients, one-to-one randomization, also designed for non-inferiority, and composite endpoint here, 1 year all-cause mortality and stroke. And the secondary endpoint, pacemaker rate at 30 days, and comparing to the self-expandable Medtronic Evolut. But before we go into the data of the head-to-head trials, I wanted to show you the MORENA. That was a multi-center retrospective analysis comparison of ACURATE Neo valves versus the SAPIEN valves. It was after propensity match, and it was done by 3 high-volume centers in Germany, which included 622 patients. So if you look here in the data, we're talking about retrospective, pre-selected patients for a valve, and then retrospective analyzed data, and then propensity matched. We have early safety points, which were comparable device failure composite endpoints, And what you can see is you had a higher pacemaker rate here for the SAPIEN valve and a lower PVL leak for the SAPIEN device. But also, that is also what we see sometimes in our practice, that you have some patients for the SAPIEN 3 valve, if you use the very small valve in the lower range of where you can use a 23 millimeter valves, that you sometimes have elevated gradients which are more than 20 millimeters of mercury mean after implant. So these are like data which are from retrospective studies which have pre-selected patients, and then we have the SCOPE trial which compared also those two valves, which was a prospective multi-center randomized non-inferiority trial, 1-to-1 randomization, and the composite endpoint of combined early safety and clinical efficacy at 30 days based on the VAR criteria. And here were the results. The primary endpoint was the ACURATE Neo valve was 24 compared to 16 for the SAPIEN valve. And if you look at this, the non-inferiority was not established according to the primary endpoint. But we can look at the different kind of all-cause mortality at 30 days, stroke at 30 days, was comparable. Life-threatening bleeding or disabling bleeding was 4% with the ACURATE valve, 2% with the SAPIEN valve. Major complications also trend to a little bit more with the ACURATE Neo valve. And one thing which I'm going to discuss a little bit in details after is the acute kidney injury, which was higher in the ACURATE Neo group, and also the valve-related dysfunction. So we go to the dysfunction. So you did have more moderate leaks with the ACURATE valve. So it was 9.4% compared to the SAPIEN valve, only 2.8%. And that caused also like why you had more higher device failure rate in that cohort. But as you can see on the other side of the columns, you see that you had 0.6% higher gradients than 20% and 2.2 with the SAPIEN. So this was the explanation for the paravalvular leak and device failure. And the other thing which was a little bit worrying, as you can see on the side, that you had a higher rate of acute kidney injury. Why is that caused? So you had much more pre-dilatation with the ACURATE Neo, because it's sort of recommended in the IFU that you do pre-dilatation. So 88% compared to 23 direct implants of the SAPIEN valve. And you had a post-dilatation rate, which was 50% compared to 13% of the SAPIEN valve. You had a little bit higher procedural time, and you had more use of contrast. And maybe more use of contrast, longer procedural time translated also into the fact that you had a higher acute kidney injury in the group of the ACURATE valve. So a little bit lessons learned from this. You had a higher paravalvular regurgitation. You had much more post-dilatation to attempt to correct that paravalvular regurgitation. You had consequently, because you do pre-dilatation, post-dilatation, longer procedures, you use more contrast, and therefore, hypothetically, you create more acute kidney injury for the patients in the group of the ACURATE Neo. If we look at pacemakers, it was very much comparable what the ACURATE Neo and the SAPIEN did. ACURATE Neo with 10% pacemaker rate, SAPIEN 3 was 9% pacemaker rate in the SCOPE 1 trial. So it demonstrated that you could achieve good hemodynamic results, but you had a higher rate of PV leak and more acute kidney injury. So if you hypothesize that you decrease the PVL, that may also decrease the need for post-dilatation, and you have then with a device advancement, shorter procedures with less contrast, maybe you have also less acute kidney injury in this patient subset. So let's look a little bit into the data, how the ACURATE valve is compared to the self-expandable Evolute, and there was one also propensity matched retrospective analysis, which was published last year by the group in Milano from Pagesi. They compared 250 in each arm propensity match patients which received ACURATE valve versus the self-expandable Evolute Pro valve. And what you can see those here, you had a very similar device success rate. You had moderate to severe paravalvular regurgitation, a little bit more in the group of the ACURATE Neo than in the newest advancement of the Evolute platform. You had a little bit higher all-cause mortality. You had a little bit higher vascular complication. You had a little bit higher also cardiovascular mortality. But if you look at the pacemaker rate, it was a little bit higher in the Evolute group. So in the end, you had very comparable results here. And let's see how that translated into the data which we just received, which were published at TCT about the SCOPE 2 trials, which was the randomized trials, prospective multicenter for non-inferiority, combined endpoint, all-cause mortality and stroke at 1 year. And we had also the secondary endpoint in this study with the pacemaker at 30 days. So if we look at the results, and these are the slides which were just presented at TCT, the primary endpoint was in numbers, 15.8% reach of ACURATE Neo valve, while 13.9% with the core valve Evolute. So they used in the study both platforms, the Evolute R and the Evolute Pro. And if you look at the pacemaker rate, you had around about a pacemaker rate of 10% with the ACURATE Neo valve, while 18% with the Evolute platform. But if we look into the primary endpoint was failed for non-inferiority for the ACURATE valve. If we look into the particular subsets, as you can see, you had also in the ACURATE Neo group here, like we've seen also in the studies before, a higher rate of the paravalvular regurgitation. And this was a core lab assessment at 30 days, which was 9.6% in the ACURATE Neo group and 2.9% in the Evolute group. The 1-year echo data is not really that comparable because there was a lack of follow-up echoes in the study, which doesn't make these data too much comparable. But the 30 days, there was included a lot of echo data, which was core lab assessed. And if you look at all the secondary endpoints, you can see that there was a significant higher cardiac death in the ACURATE Neo group, but a significant lower pacemaker rate in that group. So if you look at the study limitations, as I mentioned, you can see it on the right in the blue column. We had there was a problem in the follow-up echocardiography, which was only to a fraction of the patients available. Follow-up was limited at 1 year, so maybe you missed some meaningful long-term data and also data on valve durability. And the trial was not powered to show differences with regards to clinical endpoints, with the exception of the permanent pacemaker implantation at 30 days. So if you conclude this trial, and this is what the investigators, where we also took part in the trial, were coming to the conclusion that TAVI with ACURATE did not meet the non-inferiority criteria statistically with respect to the composite endpoint of death and stroke at 1 year. In the secondary analysis, that cardiac death was increased at 1 year in patients who received the ACURATE Neo valve, and that the two bioprostheses differed in regards of the degree of aortic regurgitation and the need of pacemaker implantation. So if we conclude this a little bit, we had 9.6% paravalvular regurgitation at 30 days in the ACURATE Neo group. And you can also postulate that maybe this translated in the higher cardiovascular mortality at 1 year of this patient group. So what's happening on the market? And as you can see, it's the ACURATE neo2 is already CE marked, and it's been used also in the US already for study. And we started in Germany to have a limited market release. And the main feature is also that you have a higher skirt, which will give this valve a better sealing around the annulus to avoid the paravalvular regurgitation. So maybe you can expect from these that you have the less need for post-dilatation, shorter procedures, and that may also translate into less contrast use and less acute kidney injury afterwards. So if we review the evidences, so ACURATE neo has demonstrated solid clinical outcomes, not only in registries, but also in head-to-head trials. The ACURATE neo failed in both trials, scope 1 and scope 2, to meet the non-inferiority criteria defined by the clinical endpoints. And the device improvements of the neo2 maybe have the potential to reduce paravalvular leak and less need for post-dilatations, but you will also need further head-to-head trials with a neo2 and longer follow-up periods to see also the question of valve deterioration and see how the long-term results of these comparable valves are. Thank you very much.
Thank you very much, Wolf. That was a very excellent overview, to be honest with you, and try to explain and some justification for the technology and the coming technology in the future. Because of the time, we have to move to our colleague from UK, Daniel Blackman, and he will talk about mastering the complex anatomy and maybe some case review. Daniel.
Thanks, Mohammed. I think I just need Alexander to stop sharing his screen. Okay, good. Great. Thank you. Well, I'd like to thank firstly Mohammed, the team in Saudi Arabia, and the Boston Scientific team for inviting me to talk about the Lotus valve. I'd like to apologize because all of the things that were covered about ACURATE are going to be covered in one talk. So this is going to be a little bit longer, but bear with me. Hopefully it'll give you a good idea of the Lotus Edge valve, and in particular, where it may play a role in your practice for complex valve anatomy. So for those of you who aren't familiar with the Lotus Edge valve system, it's a fairly unique design in that it's a mechanically expanded valve rather than being self-expanding or balloon expanded. It consists of a braided nitinol frame, around the bottom half of which is an adaptive seal, which is somewhat more bulky than many of the other sealing skirts that we see on the other devices, and probably as a result of that appears to be more effective in delivering very low rates of paravalvular leak. The gradual controlled expansion of the valve makes it consistent and reproducible and atraumatic. So it's very gentle in the way the valve is expanded, and I'll come on to where that can be useful later on. Lotus is also unique, particularly after we lost direct flow, in being fully repositionable and retrievable up to the point where it's 100% deployed. So you can deploy the Lotus into its final configuration, exactly how it will be when you let go of it, before you let go of the valve and decide if you like the result, or if you want to redeploy it in a different position, or even if you want to retrieve it altogether and take a different size valve for the rare occasions where you may have misjudged the sizing. The Lotus is an intra-annular valve, not supra-annular. The way the valve is deployed from the bottom up means that the valve functions early, so you have a functioning bioprosthesis before you splay open the native valve. And this means there's no loss of blood pressure during valve deployment, which has benefits, particularly in hemodynamically unstable patients. And the final key characteristic, which is for the Lotus Edge valve, the latest iteration, is the so-called depth guard technology, which essentially functions to limit the depth that the implant goes into the left ventricular outflow tract during deployment in order to reduce interaction with the conducting system and reduce the need for a permanent pacemaker. The Lotus valve has been around for some time. The Reprise 1 study was in 2012, So we now have a fairly extensive catalogue of trials. These are with the original Lotus valve technology here. I'm not going to go through all of this evidence, but I'm going to focus with the original Lotus valve on the Reprise 3 trial, which was the US pivotal study in high-risk patients and was the first major head-to-head trial where patients were randomized 1-to-1 between the Lotus valve and the self-expanding core valve. These are the primary endpoints of that study. The primary safety endpoint was a 30-day composite of mortality, stroke, major bleeding, AKI, and major vascular complications. And you can see that the survival free of events, or the event curve, in fact, in this one was superimposed for the two technologies. When we look at the primary effectiveness endpoint, which is a composite of death, disabling stroke, and moderate or greater paravalvular leak, then this showed superiority for Lotus over core valve, with a primary effectiveness endpoint at 12 months of around 16% versus 26%. This superiority for Lotus was primarily driven by a much lower rate of moderate or worse paravalvular leak, 0.9% with Lotus at 12 months, compared to 6.8% with core valve. Interestingly and slightly surprisingly, there was also a significantly lower instance of disabling stroke with Lotus. It may be that this was just the play of chance, but it's certainly reassuring at least. And in contrast, perhaps, to the cardiac death we saw in Scope 2 just recently at TCT, there was no difference between the two valves in all-cause mortality at 12 months. Now, the key and perhaps the most impressive result in Reprise 3, and which is seen consistently with Lotus, is the remarkable low instance of clinically significant paravalvular leak. Every Lotus study has shown moderate or severe paravalvular leak of less than 1%. And this slide summarizes that in comparison to all the other major valve platforms currently available, and shows that Lotus consistently has the lowest rates of any transcatheter aortic valve for paravalvular leak, and similar to the surgical arms of the TAVI trial seen with Evolute and Sapien. Now, the flip side to Lotus is the relatively higher rate of pacemaker, and these three major studies with the original Lotus version of Lotus valve show that the pacemaker rate was consistently around 30 to 35%, higher than that seen with any of the other major valve technologies. Now, with the Lotus Edge, which is the latest iteration available, again, there is a family of trials that's ongoing. The most important of which will be the Reprise 4 trial, which is the intermediate risk pivotal US study, which is currently enrolling in over 600 patients. This is a single arm registry study, but which includes a bicuspid cohort of 100 patients. In Europe, we've been recruiting patients to the Respond Edge patient trial, which is a 200 patient post-market surveillance registry, so real world practice. And the first 100 patients data were presented at TCT last week. These are those data. And if we look first at the VARC2 safety endpoints, we can see these were reassuring. No patients died, and there were low instances of other major VARC2 complications. If we look at the pacemaker rate, which is a key factor we're interested in with Lotus, we can see a positive signal, albeit in only 100 patients, that with the Lotus Edge and depth guard technology, the pacemaker rate appears to be lower, 18% in the whole study population, 24% if we exclude those 25 patients who already had a pacemaker. If we look at the data on aortic regurgitation, we can be reassured that with Lotus Edge, these are equally good to those seen with the original Lotus valve, with no patients having moderate or severe paravalvular leak at discharge. And having contributed a significant number of patients to this study, I can tell you that we were still including our most hostile calcific anatomy, which is where we particularly favor Lotus in my center. So just to go back to the pacemaker rate, these are on the right, you'll see a series of registry studies in the darker green with the Lotus Edge valve, showing that it does appear that the pacemaker rate is coming down. Still around 15 to 20%, but certainly lower than we saw with the original Lotus valve, through a combination of depth guard technology, which was a change in the timing of deployment to reduce depth of valve the depth the valve dived into the LVOT during deployment, and also a change in the deployment technique. So I'm going to try and focus for the rest of this talk on the place of Lotus in complex anatomy, and specifically in patients with severe calcification and with bicuspid anatomy. So why might we favor Lotus with severe calcification? Well, firstly, and most obviously, as I've shown, it has the lowest incidence of paravalvular leak of any valve. And secondly, I think importantly, particularly with LVOT calcification, the Lotus valve minimizes risk of annular rupture. Firstly, because the controlled mechanical expansion avoids any sudden increase in pressure to the surrounding anatomy. And secondly, because the paravalvular leak is so infrequently seen that there's minimal need for post-dilatation, which can lead to annular rupture even with self-expanding technologies. In the Reprise 3 study, a post-hoc analysis divided the patients into those with high and low calcium burden in any part of the aortic valve complex. And you can see here that in the patients with low calcium burden on the right, even in those patients, Lotus was associated with superiority for paravalvular leak, moderate or severe compared to core valve, less than 1% versus 4 or 5% at 1 year and 30 days respectively. But what's most striking is when we look at the patients with high calcium burden, the incidence of moderate paravalvular leak with core valve shoots up to 12.5% at 30 days and 14.7% at 1 year. Even in these more challenging patients with high calcium burden, moderate or severe paravalvular leak remains less than 1% with Lotus. What about if we look at perhaps the most feared patients in the TAVI arena, those with significant left ventricular outflow tract calcification? Well, these are fairly recently published and I think very powerful data from a single center registry from the burn unit of Stefan Windecker, Thomas Pilgrim and colleagues. They looked at over 1,600 consecutive patients who underwent TAVI in their center. They retrospectively analyzed the CTs, and they determined through a combination of objective and subjective categorization, those patients who they felt had moderate or severe LVOT calcification and those with none or mild. Moderate LVOT calcification meant LVOT calcium extending more than 5 millimeters into the LVOT. Severe was more than 10 millimeters or with multiple individual bars of calcium extending more than 5 millimeters. I think the first thing to point out is that it was actually 25% of the entire cohort who had moderate or severe LVOT calcium. So this is not really a niche group. It's pretty common in all of our routine clinical practices. And the second obvious finding was that those patients with moderate or severe LVOT calcium had a higher incidence of requirement for a second valve, of annular rupture, and of significant, i.e. moderate or severe paravalvular leak. Now, when they looked further at the type of valve used, we looked firstly at the need for a second valve. They found that with the balloon expandable SAPIEN technology and with a number of self-expanding platforms, significant LVOT calcification translated to an increased requirement for a second valve. However, with the mechanically expanded Lotus valve, there were no patients who required a second valve, as we'd expect from a valve that we can deploy fully before we decide whether to release it or not. Looking at moderate or severe paravalvular leak, again, with both balloon expandable and self-expanding technologies, a significantly higher incidence of moderate or severe leak in the patients with significant LVOT calcification, but no difference with the Lotus, where moderate or severe paravalvular leak remained only 2%, 1 out of 47 patients, even in this most hostile anatomy. And finally, annular rupture was seen in 4% of patients where treatment was with a SAPIEN valve with a moderate or severe LVOT calcium. Still one patient with self-expanding technologies, and this was in relation to post-dilatation, but no patients with the Lotus valve had annular rupture, even where there was significant LVOT calcification. So here's an example of a case of significant LVOT calcification from my center. You can see from the CT here that there was a huge chunk of calcium at the level of the annulus, shown in the top left panel. This extending down into the LVOT, and you can see in the bottom panel there, this would have been classified in the burn study as severe LVOT calcium with this shark's tooth appearance extending 13 millimeters below the basal plane. This was a patient that we actually treated from a subclavian approach, and Lotus, with its pre-shaped curve, is quite well suited to subclavian, either surgical or percutaneous access, and we've done both with Lotus in our center. Now, we chose to pre-dilate with this patient, but Lotus is quite well suited to direct deployment. In fact, with severe LVOT calcium in our center, we now tend to deploy directly, so we're even avoiding any risk of pre-dilatation causing annular rupture. This was a case with the Lotus Edge valve with depth guard technology, so you can see that the valve is not extending very far into the LVOT at any point during the deployment. Here we see the valve where it's locked in place. This is the final configuration of the valve. It's fully deployed, but as you can see, it's still attached to the delivery system. This means that we can do anything with this valve still at this point. We can reposition it, we can retrieve it, take it out altogether, come back with a different valve if we want. But we can see here that pre-release, we've got a good result. The valve position is satisfactory. We can see that we're sitting nicely below the left main stem origin. There's a mild or perhaps trivial leak. So we're happy to go ahead and release the valve. And here's the final result, which I think you'll agree in this fairly challenging anatomy with severe LVOT calcification is truly an excellent one. Let me show you a second case, which I think we might call the very extreme of hostile anatomy, with extensive calcification at the level of the annulus on the left, extending and extruding into the lumen at the level of the annulus, and on the right at the level of the LVOT. This is 4 millimeters into the LVOT. 3 separate large bars, some of which extend out with the LVOT. Now, this was a more challenging case, and despite an initial small pre-dilatation in this case, the valve deployed initially with this asymmetric configuration, which means the valve's not expanding properly. Now, this is something that can occur with Lotus, but can be used in these hostile technologies as a mechanical pre-dilatation, which has less risk due to submitting less radial force than a balloon pre-dilatation. When this happens, you can partially retrieve and reposition the valve, which you can see we've done here. And now the valve is expanding in a normal symmetrical fashion. We can go on to deploy the valve. And again, here we see the valve fully locked, just before full locking, in fact, but almost at its final configuration. We can assess the valve. We can see that because of the severe calcification, there is quite an indentation on the valve at the level of the cusps. But despite that, we have a pretty good result, perhaps with mild paravalvular leak. Again, we could still choose to redeploy the valve, see if going slightly deeper or slightly higher result in a better functional result. But in this case, we felt that given the anatomy, this was a satisfactory result, and we released the valve. This was the result following release, and you can see that we've got a good result, but we do have at least mild paravalvular leak. Now, it's rare to do this, but you can post-dilate the valve, the Lotus valve, if you feel the need to. But what's important to note when post-dilating the valve in the Lotus is that we're not attempting to overexpand the valve. We're not trying to make the valve bigger to deal with a paravalvular leak. What we're trying to do is to make the valve expansion more symmetrical. So conventionally, we'll take a non-compliant balloon that's 3 millimeters smaller in diameter than the anatomy and the valve. So this annulus was just under 25 millimeters. We deployed a 25 millimeter Lotus, and we post-dilated with a 22 millimeter non-compliant true balloon, aiming just to get rid of that waste on the valve to improve the expansion. And this is a 22 millimeter Lotus true balloon you'll see going up in the Lotus valve. You see how it just pushes the waste away, so we have a more symmetrically expanded valve. But because it's only 22 millimeters, we'd hope that the risk of a trauma to the anatomy and particularly annular rupture should be low. Here's the final result. After that post-dilatation, you can see a much better expanded valve, and now we have almost zero paravalvular leak in what was really horrendous anatomy. So what about bicuspid anatomy? Again, I think, we all recognize this as challenging for transcatheter technology. There's frequently asymmetric morphology with an elliptical annulus, often a dominant sinus with asymmetric cusps, making positioning more challenging. Severe and asymmetric calcification is frequently seen. There's often a horizontal aorta, and there's often progressive aortic dilatation, which can lead to risk of dissection and rupture, both at the time of transcatheter aortic valve implantation or in the future. So these anatomical challenges, as I've said, can make valve positioning more challenging and increase the risk of embolization. It can lead to non-circular valve deployment, which may increase gradient, potentially could affect durability, potentially could affect, and there's some CT evidence to suggest it does increase the risk of valve thrombosis, will increase risk of paravalvular leak, increase risk of annular rupture, and increase risk of aortic dissection. And there are multiple studies that have shown worse outcomes with bicuspid valve. This is one meta-analysis of 9 studies showing an increased risk of paravalvular leak in bicuspid versus tricuspid anatomy, an increased risk of conversion to surgery. Again, I think what's important with bicuspid anatomy is to recognize that not all bicuspid valves are the same. And this was a large analysis of the TVT data set with the SAPIEN valve technology from Raj Makar and the Cedars-Sinai group. And they categorized bicuspid anatomy from the TVT registry in according to calcification of the raphe and of the leaflets. And they divided up those patients and analyzed them according to whether both calcified raphe and excessive leaflet calcification was present, one or the other or neither. And you can see that when there was both calcified raphe and excessive leaflet calcification, so that's the red bars, there was, even with the SAPIEN valve, there was a 14% incidence of moderate or worse paravalvular leak, a 5% increase of aortic root injury, which you can take as code for annular rupture, and very high mortality, increased risk of major vascular complication, and not surprisingly, a quite high 30-day mortality. So why might we consider using the Lotus in bicuspid anatomy? Well, as I've said, the valve deployment is controlled. It's fully repositionable up to 100% deployed. So these two characteristics mean we can tailor the implant position. When the anatomy is confusing, we can put the valve where we want, and if it's not the right place, we can put it somewhere else. We have the option of deploying the valve high in the leaflets, using the leaflets to anchor and seal the valve, which frequently optimizes the result with respect to paravalvular leak, but also minimizes interaction with the conducting system and AV block. We can size the valve flexibly. There's a lot of interest in the option of undersizing in bicuspid anatomy. And we can do this with the leaflet valve, with the Lotus valve. We can see if the valve is anchored with an undersized valve, and we can change the size if necessary. And there should be no risk of embolization with Lotus, because you won't let go of the valve until you're confident it's anchored. As I've said before, it has the lowest paravalvular leak rate of any valve, and there should be virtually no or no risk of annular rupture. What data do we have? They're fairly limited at present. This is analysis that I did with co-investigators from the RESPOND registry, which is a 1,000 patient registry and included 31 patients with core lab confirmed bicuspid anatomy. But you can see that these data were provisional data were reassuring. There was no difference in gradient in the bicuspid patients. And in these bicuspid patients, there were still none that had moderate or severe paravalvular leak, either at 30 days or 1 year. As I've said before, from the enrolling REPRISE 4 study, there's a 100 patient predefined bicuspid subgroup, which should give us some further and stronger data with the Lotus Edge valve. So let me just show you one case example from Leeds, of which would come into Raj Makar's most high-risk group from the TVT analysis. This is a type 1 bicuspid valve. The middle bar showing the middle a panel here showing severe calcification on the right. You can see at the level of the annulus a really quite horrible rock of calcium. Here's the aortogram. There's a bit of a delay on the videos running, so I apologize for that. But you can see that this is a kind of typical bicuspid valve with a very large sinus of Valsalva, very extensive calcification, and this very big rock evident in the extending into the LVOT from the annulus. With bicuspid valves with Lotus, we do recommend you always predilate in order to facilitate expansion of the valve, but the predilatation can also be useful in showing the waist on the valve you see with the cusps and the level at which you might be able to deploy the valve and anchor it in the cusps. I'm going to jump straight here to the Lotus valve with the valve here fully locked, 100% deployed, but still attached to the delivery system, allowing us to judge the implant. Now you can see that we've deliberately deployed this valve in a high position. It's actually sitting above the level of the annulus of the non-coronary cusp. So there should be no interaction with the conducting system, even if the membranous septum is 0 millimeters in length. But you can see that there's a waist on the valve produced by the calcified leaflets on both sides. And this tells us that this valve is anchored, it's locked in at the level of the cusp. So we can release this valve with full confidence that there's no risk of embolization. We can see from our aortogram pre-release that we've preserved coronary access. We've got virtually no paravalvular leak. So here we are with the valve released. and the final aortogram to assess the final results. Again, the valve sitting nice and high. We had zero gradient in this case and trivial paravalvular leak. So in conclusion, the Lotus Edge valve is a unique mechanically expanded technology which offers complete control of valve deployment and best-in-class paravalvular leak. It offers excellent results in severely calcified anatomy, and I would personally argue it's the valve of choice in those patients with LVOT calcification, as it offers minimal paravalvular leak and no risk of annular rupture. It offers complete control and therefore good clinical results in bicuspid patients, including that subgroup with the most challenging calcific bicuspid anatomy. Thanks for your attention, and I'll be very happy to take any questions.
Thank you very much. I think we will delay the question till the last speaker. And Dr. Wolf Alexander will talk to us about TAVI-related stroke. Is it still an issue nowadays?
Yeah, is stroke still an issue? I'll just open my presentation. I hope everybody can see the presentation.
Yes.
Yes, okay. Stroke still an issue. Yeah, if you look at the data of stroke rates among several studies in the high risk, intermediate and low risk criteria, you can see that also like the stroke rates from high to low risk over the time declined. Yeah, and so when we started with the first trials, I remember we had the Partner 1 trial, and back then it was stroke was a big issue. Everybody was talking that TAVI has higher stroke rates than CABG, than aortic valve replacement, the surgical option. Yeah, and nowadays these stroke rates declined. Yeah, and this is also due to the fact that the delivery systems they were smaller, the time of manipulation was smaller, and everybody got better with the procedure and faster with the procedure. But the question is stroke something which is still very important in the TAVI business nowadays? The question is, the stroke rates decline, yes, but is it maybe something that we're missing in the data? And if you look at the data from these analyses which were done with neurologists on board, yeah, they detect much more strokes than we have seen in the TAVI trials. Why is that? It's because maybe they have a little bit more specific clinical details they pay attention to. They maybe order earlier imagings if they are on board in the stroke, post-TAVI stroke assessment. And maybe it is the fact that if you leave it up to just the cardiology units, maybe we are underreporting because we are underdiagnosing the cerebrovascular events and clinical features of the patients. Another thing which we've learned over the time is that if you do TAVI, most patients have lesions in the brain. They're usually little lesions which you can detect by MRI, and as you can see on the panel, it ranges between 65 and just about 100% of the patients which receive post-TAVI an MRI, they have lesions in the brain. But maybe these lesions don't really translate into manifest clinical apparent situations which make you think of a stroke. So there's no neurological test which can detect it, although they have these lesions in the brain. So major stroke, disabling stroke, of course, that is something which you clinically see clearly. Then you have these subtle and maybe sometimes transient ischemic attacks, minor strokes, which you can also see on clinical events. But maybe, which is maybe clinically unrecognized, is the neurocognitive deficit which patients can have because they have these lesions in the brain. And that can be detected by minimental state exams, by neurocognitive test batteries, or neuroimaging. So maybe what we see in the clinic when we just look at our patients, if they have a stroke or not after TAVI, it's just the tip of the iceberg as that image shows. And if you look at stroke impact, 30 days mortality, it's obviously clear that if you have a stroke, it has a dramatically worsened prognosis and outcome of our patients we treat. So there's a meta-analysis which shows, like, of course, the mortality after 30 days goes 4-fold up and even 6-fold up in that meta-analysis, which is posted on the right. And that also translates into late bad mortality. So this is 1- and 2-year data mortality after TAVI in patients who had a stroke. You can see 1-year mortality 67% and 2-year mortality 83%. So if you have a stroke during TAVI, no matter in what risk category you were before, you have a really bad prognosis after. And if you look at the incidence, this is also one thing which I am very happy to share with you, because it also depends, and that is something which we've seen in our German quality assessment registry on the aortic valve replacement, that it depends on the volume you do in a center annually. So if you have a certain cutoff, it is around about 200 procedures per year per center that your event rates go down, and they're optimal for centers which do 200 procedures per year and more. An important factor is, when does stroke occur? And there's late cerebrovascular events after 30 days. And then you have the event rates, which range from 1 in the first day where you receive the TAVI, which is the highest, in the subacute phase, which is the first 72 hours. But it is also the late cerebrovascular events where maybe things like new onset, atrial fibrillation, which has not been detected, or these kind of things play a role in the development of cerebrovascular events, where clearly most of the strokes, and this is about the most strokes during the TAVI, they occur within the first 72 hours. And if you look at the stroke rates, you have approximately 50% of strokes which are related to the procedure. But that means also that 50% of the strokes are maybe not procedure related, but there's also patient factors which play a role in the development of stroke. So low BMI, female gender, acute kidney disease, history of stroke, new onset atrial fibrillation. These are like patient factors which play a role in the development of stroke. These patients are at a higher risk of stroke. And there's also procedure related. And that has to do with the time of the patient in the cath lab, the time of the delivery system in the body, the amount of manipulation, valve repositioning, pre-dilatation, rapid pacing, post-dilatation. These are like factors which can translate into higher stroke rates. In the late phase, it's the chronic atrial fibrillation, the pre-existing peripheral vascular disease, history of strokes, which play a role. So that means also that 50% of the strokes which occur are probably not procedure related, and they may be related to the regimen of pharmacological regimen we apply to our patients. So this is also like the amount of heparin we give, that we have a correct ACT during the procedure, that we treat the patients after deployment with the right agents, either whether it's a single therapy, a dual therapy, if we take into respect if the patient has atrial fibrillation, that we put them in a new anticoagulation. These are factors which play a role. Can we prevent stroke? Well, there's certain concepts that you can apply. These are these cerebral protection devices, and you can see there's different kind of deployment methods. There's filters which you can deploy in the common trunk of the arm and the cerebral artery on the right side, and the carotid on the left side, which is a sentinel system. Then you have also a transradial system which you can deploy as a certain umbrella. And you can also have from the femoral side something which deflects like the umbrella, and the deflection device which not capture the debris like in a filter, but you deflect it to the lower parts of the body where the debris doesn't cause a cerebrovascular event, but causes a minor embolization somewhere else in the body. So the Sentinel system, which I want to show you a couple of pictures here, is a system which has two filters. One larger filter, which you can place in the truncus brachiocephalicus on the right side. It's a transradial system which can go through a 6-branch sheath, and it can open the first large filter in that position, which you can see on the right panel. Then it has a system which is a steerable system where you can form a certain hook, and that hook can help you to access with a coronary wire to the left carotid artery and deploy the distal filter there. What is not protected is the subclavian artery, where the vertebral artery to the left origins. And this is an area which is not protected by that particular system. So if you look at the percentages, it's around about 90% of the cerebral flow is protected, while 10% are not protected. On the lower panel here of that slide, you can see how the delivery system works. There's numbers indicate you which steps you have to do when. It's a very intuitive device to use. Interestingly, there's been a whole lot of studies done. What can you find in these filters when you analyze them in histopathology afterwards? And interestingly, it's you don't really have acute traumas which is standalone in these filters. Yeah, you have a little bit organized traumas, but you have foreign bodies. 1/3 of the filters will form foreign bodies, calcifications, and valve tissue. And this gives you also an indication if you have a patient on the table which has an acute stroke, just to translate that into clinical practice, it's very unlikely, like if you have these solid pieces which are stuck to your arteries in the brain, that maybe like, you know, a pharmacological approach to which you use in acute stroke with a lysis therapy might not work, but it's probably better to think about a retrieving strategy, how you can pull these really chunks of calcium or valve tissue or arterial wall out of the artery to restore flow. So the data which we have concerning the cerebral protection systems, there was a first in man, then you had the Mistral 1, Mistral C from the colleagues in Rotterdam, which did studies. There were mainly a registry. Clean TAVI was a randomized trial. Mistral C was also a randomized trial. And then you had the Sentinel IDE trial, which helped to get the FDA approval in the United States. So that was a prospective randomized trial with 363 patients at high surgical risk for TAVI, and a safety arm of 123 patients, and a device arm of 122, which received the Sentinel system, and a control arm which did not receive the Sentinel system. And the centers were in the United States and in Germany. So the primary endpoint was a safety endpoint. Oh, sorry. And so you had, so the safety endpoint was reached, yeah, and the device received FDA approval in the United States. But the second thing which they also detected in that study was that they looked for these new lesions and the volume of those new lesions in protected territories. And you could see that you had a 42.2% reduction of volume calculated by MRI scan in the brain, less when you use the Sentinel system. Here is again the chart how that study worked: severe aortic stenosis, then randomization in 3 arms: the safety arm, the test arm, and the control arm. And you had the clinical follow-up, which involved also a neurologist and MRIs. So as you can see, the patients which didn't receive a Sentinel and the safety and the test arm had numerically less strokes, 5.6% compared to 9.1%. But also that study was a safety endpoint and not powered for a clinical hard endpoint as stroke. So, but what you can see is that especially this first day and the next 2 days are very critical for these patients. And you had a 63% reduction using the Sentinel system compared to the patients which didn't receive the Sentinel system. Also, if you look at these analyses of the clean TAVI Mistral Sentinel IDE trial, you can see that you are in favor of using that cerebral protection system in order to avoid your patient having a stroke. So if you look here, it's also like data which have been pooled data, meta-analysis of these 5 randomized trials favors the embolic protection towards not using the protection. But it's at the moment a suggestion because we do not have any clinical trials which have a hard endpoint of stroke so far. But that will change, and we will have 2 trials which are at the moment already, the protected TAVI, I know it's already recruiting. It's patients, it's 3,000 patients which will be included in this trial. It's transfemoral TAVI. It's an obligatory neurological exam in all patients pre and post procedure. It will be randomized 1-to-1 patients without cerebral protection and patients with that Sentinel device. And this study has a primary endpoint of stroke at 72 hours or discharge. And this is probably the lack of data we were missing in order to determine for hard clinical endpoints whether these protection devices are important to use in your patients. And the second trial, which is a larger number, it's going to be 7,730 patients. It's from the British Heart Foundation. And it's a trial also randomizing 1-to-1 patients with protection devices with patients without protection devices, also primary endpoint, discharge or stroke at 72 hours. And it will have a planned analysis for efficiency and futility at 50 and 70%. So if TAVI is a stroke still an issue? Yes, it is still an issue, especially if we're thinking about moving to lower risk patients and younger patients, because it has a dramatic impact on mortality and quality of life. We don't really know how much the silent lesions in the brain are associated with neurocognitive impairment and earlier onset of dementia. We don't know these things, but it's quite a frightening factor that we know that minimum 2/3 of the patients will have silent lesions on MRI scans after a TAVI. 50% of the strokes are procedure related, 85% occur within the first week. Monitoring for new onset atrial fibrillation remains also important in the follow-up and treatment of the patients and stroke prevention in the long run. And cerebral protection devices can reduce the volume of MRI that we know so far of the new lesions. And it demonstrates at the moment, I would call it a trend towards lower stroke rates. And I'm really looking forward for the data for the randomized trials, which I just showed to you with a clinical endpoint of stroke. Thank you very much.
Thank you very much, Dr. Alexander. And I might allow 1 or 2 questions from Dr. Faisal to Dr. Blackman. Go ahead, Faisal. We don't have a lot of time.
Thank you. I just want to have a comment and a question about the Lotus. Have you noticed any change in the gradient when the device is not symmetrical post-deployment when you post-dilate? Does the post-dilatation that change the device shape translate into a change in the gradient? Should we go by the device shape or just the gradient post-deployment?
Yeah, it's a great question. I mean, so you'll see with Lotus from the studies that have been published that the gradients in general are pretty similar to the gradients you see with other intraannular valves, about the same as you see with Sapien. So in the studies, the average mean gradient is about 11 millimeters of mercury. So most patients have favorable hemodynamics. However, it's certainly the case that when you use Lotus in really extreme anatomy, and in particular severely calcified bicuspid anatomy, that you may see this, what I showed in my second LVOT calcium case, a big waste on the valve. Now, the valve leaflets are suspended from the posts, and that's independent of the frame. So you should normally get normal valve function even when there is indentation of the frame. But in a minority of patients, you do see a gradient. And that's when we've tended to post-dilate in our own practice in Leeds. Now, you don't have to post-dilate. Some Lotus operators prefer to redeploy the valve and would argue that you get better expansion of the frame second time around. You may redeploy in a second spot. What we tend to do is deploy the valve, and then if we do measure a gradient after release of the valve, then we post-dilate with an undersized non-compliant balloon, and it does improve the gradient. So we've actually got a series between Leeds and a few other centres that have post-dilated of about 50 patients that we're going to be presenting as a poster at PCR London Valves. That's mostly post-dilatation for a small residual gradient, some for paravalvular leak, and showing good efficacy in terms of reducing the gradient and fixing the leak when there is a leak. But I think it's worth emphasising that it's a minority of patients. So in Leeds, we've probably post-dilated 5 to 10% of patients, and we're the biggest enthusiasts for post-dilatation that I know of. So.
Just one follow-up, one question quickly. Pre-dilatation, does it affect, is there any data on pre-dilatation and the asymmetry of the shape of the valve?
I don't think there are any data on that from the studies. It's first thing to say is that in Reprise 3, pre-dilatation was mandated in the study. So all of the patients had pre-dilatation. In Reprise 4, which is currently enrolling, pre-dilatation is only mandated in the bicuspid cohort. In clinical practice, we tend to pre-dilate in about a third of patients with Lotus, but because we're often using it in very challenging anatomy, then we are tending to pre-dilate. Anecdotally, I think if you pre-dilate, you've got a better chance of getting good symmetrical expansion the first time you deploy the valve. But some people prefer to pre-dilate with what they'd call a mechanical pre-dilatation, where they use the Lotus. They go direct in any anatomy. If the valve doesn't expand favorably the first time, then they'll recapture and redeploy. So they've almost used the first deployment of the valve as a pre-dilatation, and would argue it's a safer pre-dilatation than you do with a balloon.
We have one question thank you. One question for Alexander about the cerebral protection device. What are the criteria you have in your cath lab for those patients where you're going to use Sentinel or any protection device? Wolf.
Yeah, cerebral protection devices, we use them in patients which have, for example, something which we call a hostile arch. A hostile arch is an arch which has massive calcification, and it's maybe not a porcelain aorta, but it's also like that there's really calcium chunks which are sticking on the arch, so the manipulation can cause these calcifications to crack and embolize. And also like when they have a lot of soft plug in the CT scan, in the aorta. That is one criteria where we use cerebral protection systems. If the patients also have patients factors like prior stroke, let's say the patient has a high risk for stroke from the screening, from the beginning, we are very tend to use these cerebral protection systems. But you also have to give the anatomy. These cerebral protection systems, you can, in our center experience, you can place both filters in about 90% of the patients. Not every anatomy is suitable. So if you do a lot of radial cath, you know that some anatomies are just impossible to master the radial access for a PCI, let's say. And then sometimes these, let's say hostile anatomies, they also apply sometimes to the sentinel system. But 90% we really assess these like you can place the filters correctly.
Michalis, do you want to say anything? Michalis?
No, Dr. Barlet, it's for you to summarize. I just want to one sentence for thank you.
Guys, I think we exceed the time, but I know it's a Friday in Saudi Arabia. It's a holiday, but in spite of that, I would like to thank 440 participants during this webinar, and I think we learned a lot from our speakers. Very nice cases was presented, different variety of cases, and they showed us how they choose this device and in which phase. We learned from our colleague about the studies and especially scope 1, scope 2, TCT result. And we are hoping that the ACURATE New 2 might change what we heard from the studies. Dr. Blackman from UK, he gave us a very nice overview about the Lotus and Lotus Edge. And we could see the benefit of this device, Lotus, mainly in bicuspid valve and highly calcified aortic valve or LVOT calcification, and we could see the different result in comparison with the other valves in improvement of paravalvular leaks. And with the last speaker, we noticed a lot of maybe benefit of using a cerebral protection device, which is not a routine, but you have to select your cases. On behalf of Saudi Heart Association and myself, I would like to thank all the participants and all our friends and colleague speakers from different parts of the world, and to thank Boston Scientific.
Thank you.
Thanks very much.
Thank you.
Thank you all.